Okay, so I think we can start the program. We are already live on the YouTube. So good morning all. Welcome back to Saturday Club morning meeting. And today we have a very well-known speaker, Dr. Jitendra Mistry. He was invited as a guest speaker last year. And his formal introduction is that he's done his MS and DNB in GI surgery. Also got FAMS, FLS, and most important, he is alum of Baroda Medical College. He has specialized in hepatopancreaticobiliary and GI surgery, GI cancer, and liver transplant. His institute is known as Mission Gastrocare in Vadodara. And to his CV is very long, in fact. So if I narrate that, no, it will take 10 minutes. So briefly to say about him is that he has won several awards. He has several publications, national and internationals, as well as presentations to his credit in various conferences. He has been a reviewer of many journals related to his subject of gastroenterology. He is member of editorial board of several journals, and he is contributor of chapters to several books. This is a very brief introduction to Dr. Jitendra Mistry. And as is his very wonderful way of giving titles, he has given a very catchy title to this talk also. Even I don't know what exactly he is going to talk about, which disease. The title of the talk is, Can this patient survive? A question mark, a difficult question or a difficult disease. So now let us invite Dr. Jitendra to unravel the subject, what he is going to talk about. So over to you, Dr. Jitendra. You have about 40-45 minutes. And of course, we'll have 10-15 minutes of discussion. So over to you, Dr. Jitendra.
Thank you. Thank you very much, sir. Thank you, everyone. And good morning. Thank you for joining on Saturday morning. Thank you, sir, for managing the show from abroad. So I'll just share the screen. So my today's presentation, the title is, Can this patient survive? This is actually a story of an uncommon disease, a difficult disease, but it is also a story of persistence, or a story of situations where a person's institutional training and good mentor, how they can shape your vision and thought process, and how you can apply this vision and thought process into a difficult situations. Actually, Jagdish sir asked me to present this case in this forum. So thank you, sir, for inspiring me. So basically, on the first post-operative day, patient we operated upon, when I was taking a round in the ICU, the ICU registrar, the resident, asked me the question that can this patient survive? The way question was asked, it was more of a suggestion rather than a question. Basically, he was trying to say that we are actually wasting our resources. This patient is unlikely to make, and we are unnecessarily doing the work behind this patient. We are unnecessarily wasting the money and the resources behind this patient. And in a way, he was partially right also, because the way patient was with us, the chances of his survival was very thin. So this is a case of a 12-year-old boy who actually presented with an acute intestinal obstruction. The patient was from Jaipur and Rajasthan. Patient actually consulted somewhere else, and when X-ray and ultrasound was done, which was suggestive of acute intestinal obstruction, exploratory laparotomy was done at that place. The referral note, or the surgeon's operation note, denotes that patient had an abdominal cocoon, and he slit open the abdominal cocoon. After surgery, patient deteriorated, and so patient was shifted to us. So that is the initial history of the patient. Now, what is cocoon? By a literal meaning, cocoon is actually an envelope or a casing for the larva. It is basically a casing in a larva stage of the many worms, which protects the larva from surrounding danger. In a verb form, it is also mean that it will stay inside and be inactive. So abdominal cocoon is a similar kind of envelope or casing. It is also known as an encapsulating peritoneal sclerosis. It is actually a chronic fibroinflammatory process where a fibrous sheet-like covering is formed around the small bowel. The whole small bowel and the different organs are compressed within that cocoon, within that fibrous sheet, and they are packed so tightly that they constrict the small bowel, they restrict the bowel movement, and patient may develop symptoms because of constriction and restriction of the movement. These are few pictures of abdominal cocoon. So what we can see that grayish kind of membrane over the small bowel loop is actually a wall of abdominal cocoon. So when we open the abdomen, you cannot see any bowel or any organ. Everything is inside the cocoon. You can just see the membrane. You have to dissect that membrane to find out where the small bowel are. And when you start dissecting the bowel, the small bowel pops out of that abdominal cocoon. So these are the pictures of abdominal cocoon. Sometimes the cocoon abdomen, the wall of the cocoon is so plastered that sometimes we use the word called hostile abdomen. It is called an hostile abdomen because it is difficult to find out which organ is where is the small bowel. We don't know anything about it. And it just looked like a plastered wall, nothing else. Where to dissect, where to start the dissection, everything becomes difficult. And at times, we even have to close the abdomen without doing anything. So sometimes the abdominal cocoon can be very hostile and difficult to manage disease. About Aetio-pathology, there are various etiologies described in the literature. It's an uncommon disease, so we do not have a good amount of or the massive amount of the literature. Most of the things are smaller studies, and most of the things are assumptions or an hypothesis. So the commonest cause is actually an idiopathic. We do not know the cause of abdominal cocoon. In India, one of the reasons is tuberculosis, where the patient develops an wall-like cocoon over the small bowel loops, and they develop an obstruction. A very good amount of literature available for the abdominal cocoon after CAPD, but fortunately or unfortunately, we do not have any experience of cocoon after putting a peritoneal catheter for the peritoneal dialysis. Secondary to severe peritonitis, patient can develop an abdominal cocoon. There are cases reported that post liver and kidney transplant patient have an abdominal cocoon. Some of the malignancies incite a massive amount of the reactions, and patient can develop an abdominal cocoon, like neuroendocrine tumor or gastrointestinal stromal tumor. Following a VP shunt for an hydrocephalus, there are cases reported where patient has developed an abdominal cocoon. HIPEC, which is an intraperitoneal chemotherapy. So reaction to that intraperitoneal chemotherapy, patient can develop an abdominal cocoon. And endometriosis is one of the reasons, can be a cause of obstruction, and patient might have developed an abdominal cocoon. Pathogenesis wise, actually the mesothelial cells, which are the cells, which are epithelial cells lining the peritoneal cavity, inside the peritoneal cavity, they get converted into the fibrous cell, mesenchymal cells, and they develop an intense fibrosis and develop a wall cocoon around the small bowel. And that is how patient may develop an abdominal cocoon. This is an hypothesis kind of thing. So the presentations, the symptoms are because of the restrictions and constriction of the small bowel in the gut motility. Patient may have an abdominal pain or bloating, and in worst case scenario, patient may develop an intestinal obstruction. But actually, there are no specific symptoms based on which we can say that this patient is likely to have an abdominal cocoon. Most of the time, findings are actually an intraoperative findings. You operate assuming something else, and when you open the abdomen, you find an abdominal cocoon. There is no specific test also which can say that this patient can have an abdominal cocoon. A CT scan can have a certain signs like the small bowel loops are clumped in a one particular area, or the mesenteric vessels are going in that particular area, can give an indirect evidence or indirect doubt that this patient might have an abdominal cocoon. Most of the time, this disease is found on exploring the abdomen, and intraoperatively, we then most of the time we found that this patient has an abdominal cocoon. We hardly have a preoperative assumptions or diagnosis of abdominal cocoon. The symptoms are intermittent, and many a time some of the assumptions is that this can be an congenital happening, and patient may develop symptoms in an adulthood. So it's a mysterious disease. So about the treatment, as I said, as the data is not significant, the treatment part is also like a kind of trial and error thing. So only one disease, which is tuberculosis, if it is the cause, antitubercular treatment is the definitive treatment. But otherwise, the drugs which are tried in abdominal cocoon are tamoxifen, steroids, azathioprine, and certain immunomodulators like tacrolimus or mycophenolate or something like that. So these drugs are used on a kind of anecdotal base with a very small amount of literature. These drugs does not have a solid evidence, but these drugs are actually used for as an anti-inflammatory or in certain diseases. For example, tamoxifen is used for a retroperitoneal fibrosis. So it is assumed that it may work in an abdominal cocoon and help the patient. So that is how these drugs are used, but there is no strong evidence based on which we can say that these drugs are going to work, except anti-tubercular treatment. If tuberculosis is the cause, treatment is the answer. About surgical treatment, the most of the time these drugs are used adjunct to the surgery rather than standalone. Except tuberculosis, anti-tubercular treatment, rest of the drugs are actually used along with the surgery to prevent the recurrence of the disease or to help along with the surgery to the patient rather than a standalone treatment. About surgery, as the cocoon constricts and restricts the bowel into a one balloon kind of thing, the adhesiolysis is the treatment. Adhesiolysis and excision of that wall of the cocoon may help. The problem with surgical management in this disease is that at times, as I said, the cocoon is so plastered that defection is very difficult. The chances of bowel injury is extremely high. Small bowel serosal tears and sometimes stool thickness injuries. So you might need to do a ileostomy or colostomy stoma to prevent the leak. Repairing the injury is difficult because wall of the cocoon is very tough and suturing may not heal and patient may leak. So stoma is one of the things which we have to keep in mind. At times, as I said, the abdomen is so hostile that you might have to abandon the procedure. You have to close the abdomen without doing anything. At this point of time, I would like to point out this principle, which is primum non nocere, which means first to no harm. It is a very important procedure a very important principle in medical practice, that in a situation where you cannot benefit the patient, a thing you have to keep in mind that take care or keep in mind that you do not harm the patient. And it probably this principle is very pertinent in this disease, because when you operate the patient, when the disease is so difficult, sometimes you have to be careful that you are not harming the patient. You have to stop somewhere and refer the patient to somewhere else where this disease can be managed in a better way. So when this patient presented to us after first surgery done somewhere else, patient actually presented to us with a fecal fistula. So stool was coming from all over the wound, all over the abdomen. The patient had a tachycardia, tachypnea, He had hypertension. Patient was on vasopressors. He was malnourished and cachexia. A week before the first surgery and a week after the surgery, patient was not having any significant nutrition. So patient's albumin was 1.8. So patient was shifted to us on post-op 6 after the first surgery done somewhere else. So we resuscitated the patient. We discussed about the disease to the patient's relatives. We discussed about the prognosis. We discussed about the risk and risk of life involved in managing this patient, as the previous surgeons not denote that it's an abdominal cocoon. So after resuscitation and everything, we re-explored the abdomen. When we removed the stitches of the first surgery, this was the first appearance. A lot of stool inside the abdominal cavity. We gave a lot of wash and all the dissected small bowel we brought out. When we brought out the small bowel dissected loops, it was complete mass. We cannot see any normal bowel wall or normal bowel loops. Everything was an inflammatory tissue, phlegmonous tissue, a serosal tear, a mucosa exposed, a bowel perforation, a segment of small bowel were there. It was all tuberculoma actually. At the look of the disease, we could make out that this is a case of tuberculosis and abdominal cocoon. So when we opened the abdomen, we gave a lot of wash, and I recorded a small video to just give an idea what was the scene. So that's the duodenum, the region flexor where the small bowel starts. So we can see that immediately at the beginning of the small bowel, it was just a mucosa. There was no serosal layer over it. So everything was bad, dissected. And even at the beginning of the small bowel, the small amount of bowel was also not well preserved. So as seen in the picture, there was hardly anything in the bowel which can be, which can be dependent on or which can be saved. Everything was exposed mucosa, small segments of multiple small bowels, and leaking stool. Everybody in the operation theater was like, this patient is not going to make it. And suggestions from everyone was like, probably we should close the abdomen. This patient is not going to survive. Here I would like to say one story. So in this picture, along with me is Dr. Samira Nandi. She is my mentor, my teacher. I've done GI surgery from Gangaram Hospital under him. He is one of the best teacher I have ever met in my life. And I have observed that this kind of teacher, even when walking, talking, they use certain words or certain sentences, they have some deep meanings. So we have a plan in the round that he gives his mobile to one of the residents so that he can take an uninterrupted round, and the resident has to pick up the mobile. So one day he was taking a round and his mobile was with me, and mobile rang and I was trying to pick up the mobile. So I was sliding on the screen of the mobile and somehow it was malfunction and I could not pick up the phone. And during taking the round, from the edge of his eyes, he saw that I'm trying to pick up the phone, but it is not helping or it is not working. And then he said to me that, Jitendra, sometimes in life you have to persist. I picked up that line and I kept this line with me even during my practice. And as I said, some of the mentors, they use certain kind of sentences, and there are a lot of deep meanings in these sentences. So we persisted. What we did in this patient, that whatever 1 feet or less than 1 feet small proximal small bowel was there, we took some tagging stitches over the serosa and we brought out that mucosa over the abdominal wall. So it was just beyond the duodenum, probably less than 1 feet beyond the duodenum, the stoma was made. So whatever the bile or whatever will come immediately out of the abdominal wall. And we wanted to divert the peritonitis, divert the leakage of the stool inside the abdomen. It was a very proximal stoma at the beginning of the small bowel. These are the tension stitches which we took because the wound was not very well, and we anticipated that the wound dehiscence is likely to happen this patient. So we operated this patient, and on post-operative day 1, when we were taking the round, the resident, the in charge in the ICU, he asked the question to me that, so can this patient survive? And as I said, it was more of a suggestion rather than a question, that this patient is unlikely to survive, and why are we wasting our time and resources behind this patient? So the plan was, we know that it is a difficult situation, but the plan was that we'll try to build up this patient nutritionally, as it was a stoma very proximal in the small bowel. We knew that this patient is going to need a parenteral nutrition for a long time. And as it was a case of tuberculosis, proven on the biopsy which we sent during the surgery, this patient, we are planning to give an anti-tubercular treatment. And looking at the bowel condition, one thing I decided in that surgery, that I'm not going to, even if this patient makes, I'm not going to re-explore this patient before 6 months, because the bowel are actually mass. There is nothing like a good amount of small bowel in his abdomen. So as the plan was to give a nutrition and anti-tubercular treatment, but we also knew the challenges which we are going to face. Patient was already malnourished to begin with, and with a less than 1 foot of small bowel, we knew that it is difficult. It is going to be very difficult to maintain nutrition in this patient. Parenteral nutrition, how long will give? It has its own problem. It has its own cost as well. And proximal stoma, that means there is going to be a lot of fluid and electrolyte imbalance. And then anti-tubercular treatment, which drug is going to work, right? Our standard 4-drug AKT, if you give orally, whether these drugs are going to absorb, because the length of the small bowel is hardly 20-25 centimeter from the stoma. So in the first week of post-op days, we gave IV fluids and all kind of supportive treatment. It was a proximal stoma, so high output stoma. Every bile, all the bile secreted into the duodenum was coming out of the stoma. It was very difficult to maintain the hydration. A very high amount of fluid was required. Electrolyte imbalance was difficult to manage, but the ICU team, the pediatric gastroenterologist, the infectious disease specialists, they all were involved as a team, and everybody was trying to give their input and manage the patient. So first month of the surgery, the biopsy confirmed that it's in tuberculosis. But the stoma was functioning. We gave a trial of some liquid, if we can tolerate. We started on the parenteral nutrition, initially fat-free parenteral nutrition, as patient was in sepsis. And then the pediatric gastroenterologist and ID specialists, they selected the anti-tubercular treatment. It was an HRZD, which was given orally, the standard 4-drug AKT. Whatever it has absorbed and helps, they started it. And along with that, they also gave amikacin and meropenem as an antibiotic as well as an anti-tubercular treatment, because the oral anti-tubercular treatment may not absorb well. So along with that, they also gave an intravenous anti-tubercular treatment. So we actually expected those standard 4-drug AKT to work well, because they are the very effective anti-tubercular treatment, and the disease load was very high, as we saw in the picture. So we expected that these anti-tubercular treatments should work. The electrolyte imbalance was a problem, and continuously we have to give a potassium, we have to manage the bicarbonate and everything. And he continues to lose weight despite of whatever oral and parenteral nutrition we were trying to give. So immediate post-op, so it is around 2 months after surgery, he was tolerating some oral diet. He was a very adamant child, very difficult to manage. Parenteral nutrition was going on despite the cost and constraints. Anti-tubercular treatment were going on. On and off, patient kept on developing fever. He had a wound infection, wound dehiscence, which we expected. He was he was kept on losing the weight. And because it was a proximal stoma, very high output stoma, the stoma management was also difficult. There was a peristomal erosions, and the erosions are very painful. So it was also very difficult to manage. So after certain days of parenteral nutrition and antitubercular treatment, he started having recurrent fever. So after a week or 10 days of central line and parenteral nutrition, when we ruled out all the cause of the fever, the central line, the only thing which remained was the central line. So after 10 days, we removed the central line for 3-4 days so that fever subsides. But then we remove the central line, there is a gap in the parenteral nutrition. And then after 3-4 days, we reinsert the central line at some other place, and we again restart the parenteral nutrition. So multiple times, the one central line works for 10, 15 days, 20 days, and then you have to remove the central line. Another central line works for 10, 15, 20 days, and then we have to remove the central line. This kept on happening, and everything, we solve one problem and another problem arrives. So the next problem we faced was a drug-induced hepatitis, the AKT-induced hepatitis. Percent bilirubin was somewhere around 11. The liver function, the liver enzymes were deranged. So even if that with a small amount of small bowel, we expected that some standard AKT might work, we had to stop that standard AKT as well because of the hepatitis. And the liver function was probably partially deranged because of parenteral nutrition also. It was very difficult to differentiate whether it's because of parenteral nutrition and hepatitis. But obviously, the amount of enzyme derangement and the bilirubin, it was definitely a drug-induced hepatitis. So again, the physician side, they changed the antitubercular treatment. They added the levofloxacin, cycloserine, meropenem, amikacin, ethambutol. They removed the drugs which can cause the drug-induced hepatitis. They took some break in the parenteral nutrition so that the liver functions came back to normal. The drug-induced hepatitis was one of the phase where we felt that this is going to be difficult, and I don't think this patient is going to make. But still, some of the cycloserine, I've never heard that this can be used as an antitubercular treatment. So the team managed so very well. And at the 4 months after the surgery, all oral nutrition, parenteral nutrition, all deviation in the antitubercular treatment, the next problem we faced was a multiple venous thrombosis. The subclavians were thrombosed, the jugulars were thrombosed, the femoral were thrombosed, because we used all central line at different places. And then we placed the PICC line at one of the places feasible, and we managed the parenteral nutrition. Again, as I said, on and off fever was a problem. The cause of the sepsis was difficult as this patient had a multiple problem. So at 6 months, this patient stayed in the hospital for 6 months. His original weight was 38 kg before the first surgery or before the problem started. He came to us with a weight of 28 kg, and over a period of 6 months, despite the full nutrition we could afford and we could manage, he came down to 24 kg weight. He actually came down to somewhere around 20 kg and then slightly regained the weight to 24 kg, and then he was not gaining the weight. So there was a lot of a difference in the thought process also. I was trying to postpone the surgery because I know re-surgery in this patient is also going to be a mess. And the other people in the team was like, it is very difficult to manage fluid, electrolyte, and nutrition in this patient. I think we should reconnect the bowel so that some bowel can work in this patient. So this patient stayed in the hospital for 6 months. Another bigger challenge in this patient was the motivation. Motivation for the patient relatives, and every doctor involved in the team and the staff. Because we do something, we solve something, and another problem was ready to harass us. So probably apart from doing a surgery, only thing my role in this case was persistence and motivation. I kept pushing everybody that we'll keep on very hard to save this patient, and unless the nature says us that now it's an end. So we kept on pushing. We persisted for this patient despite all the challenges. You just imagine that this patient was in the hospital for 6 months to take the daily round, and you don't know what to talk to the patient. You don't know what to talk to the patient's relative. How much hope to give to this patient. But at the end of the 6 months, multiple antibiotics, multiple AKTs change, central lines, prick line, parenteral nutrition, albumin, multiple CT scans, and as I said, a lot of class of thoughts and perspectives inside the team as well. He persisted, and at 6 months, everybody was like, now we have to reconnect this bowel, it's too much. And I also felt that I think we should take chance now. So this is a picture 6 months later. That's a secondarily healed midline abdominal wound. That's a proximal stoma with some peristomal erosions. We re-explored this abdomen 6 months later. When we opened the abdomen, there was some hope. The picture was looking a little better than 6 months ago. We dismantled the stoma. That's a small bowel, and which we made the stoma, and that's a small bowel loops, which are looking much better. I must say that nature is amazing. The way antitubercular treatment in the time has worked. In the first surgery, it was only mucosa. There was no wall over the mucosa. And after 6 months, the bowel were looking near normal. The location where I did the end stoma, which was hardly 20-25 centimeter from the jejunum, the beginning. And at 6 months, even I could say that the length was increased. It was very interesting phenomena, and this is a side-to-side anastomosis. I dissected the distal small bowel also. Distal small bowel was also very well identified and were looking very well. There's a small video, the small bowel from the DJ flexor, which we took before surgery. And that's an anastomosis, right? So in the 6 months before, you could see that the end stoma was very proximal, hardly 20 centimeters from the duodenojejunal junction. And here it was almost more than 1 feet or 1.5 feet from the DJ flexure. That's a cecum, that's a large bowel, right? So that is how we reconnected the bowel. That's a picture after the surgery. That's a stoma side closed, and that's a right pyramidal incision which was tapped in the first surgery. That's a patient 3 months later. That patient came back to me for the follow-up after 3 months. I didn't know he was a painter. He made my painting, and 3 months later he came back with his picture in my OPD. We had a similar one patient, a young female, 21-year-old female, 1 month following the delivery, a 1 month of old baby, and patient had an tuberculosis, abdominal tuberculosis, obstruction. She was explored twice at 2 different hospitals before coming to us. She also came to us with a fecal fistula. When she came to us, the outside report, the hemoglobin was 6, the WBC was 1200, and platelet count was 16,000. And we said that we can only persist. We don't know whether we will be able to save this patient or not. This patient also, we did the similar kind of thing. We reoperated, we did the stoma. Patient was on a ventilator, inotropes. This girl required 2.5 months of dialysis, tracheostomy. She was discharged on tracheostomy, parenteral nutrition, oral nutrition. The first hospitalization was 3.5 months in a private hospital, and she was discharged after 3.5 months. After 3.5 months with a stoma and tracheostomy, and after 6 months, she was readmitted. We closed the stoma. And that's a picture 1.5 months, 1.5 years later after the surgery. All the pictures we use, we have taken consent to use this picture from the patient. So my data, I have managed 9 cases of abdominal cocoon till now in last 7-8 years of my practice. 7 patients were males and 2 were females. 2 patients had a tuberculosis. Both the patients are presented in this today's presentation. 1 patient had post-peritonitis, multiple surgeries, abdominal cocoon. 1 patient had a neuroendocrine tumor, and 5 patients had an idiopathic disease. As literature has a lot of cases following peritoneal dialysis. We have never have any patient with a peritoneal dialysis. One patient had a mortality, but one patient we did a surgery, but patient had a persistent obstruction. Patient went to another hospital in the city and they did the stoma. And as per my knowledge, patient survived. So I would end my talk with the summary that this abdominal cocoon is an uncommon and a difficult problem. Patient generally present with recurrent pain, and in the worst situation, present with an abdominal with an intestinal obstruction. I think this disease needs this principle to be aware, which is primum non nocere. No, if you cannot help the patient, I think stop somewhere and don't harm the patient further. The surgical treatment is adhesiolysis, and invariably you end up with a stoma because there are multiple bowel injuries. Only thing which probably works in the patient is persistent and patience from both doctor side and the patients and patient relative side. This disease needs some teamwork. And I must say, I must acknowledge that this patient was actually managed at Casiban Children's Hospital. And I must acknowledge that the pediatric gastroenterologist, Dr. Nidhi, and Dr. Kamna, the ID specialist, and the ICU team, and the Dr. Hitesh, the pediatrician there, they did a wonderful job. Except surgery and pushing them, my job was only that, but they tolerated the patient for 6 months in the hospital and they did wonder. I must say that antitubercular treatment does wonder. Even in hopeless situations, antitubercular treatment changes the picture completely and time heals everything. So with that note, I would end and I thank you very much. I hope that it was a single case, but it would be an interesting to listen. Thank you, sir.
Thank you, Dr. Jitendra. Can you hear me?
Yes, sir.
Okay, please. Yeah, fine. So congratulations to you, Dr. Jitendra, and the whole team of KGP Children Hospital for putting so much efforts, keeping the patient for 6 months and convincing the parents that there is a hope in such hopeless case. So that was very wonderful. I have a question. You had 9 patients, and out of that 5 were idiopathic. So what was the age group of all these patients? Like, does it happen in pediatric also? I mean, idiopathic abdominal cocoon?
So this 12-year boy was the youngest patient in my series.
Right. Right.
Unfortunately, I could not mention the age group, but most of the patients are adult.
Okay.
Not the pediatric.
And
the 12-year boy was the youngest patient.
Okay, steroids were used in this patient.
So another problem, see, basically, as I said in my presentation, that these drugs are actually an anecdotal or there is no strong support. But these 2 patients we have seen, most of these patients come with a very bad sepsis. We generally do not get an opportunity to use steroids in this patient. I have not used any of these medications in any of these cases. One case, it was transferred to another hospital. I've heard that they are trying tamoxifen in this patient, but I have not used any of these drugs.
Right. And what are the chances of recurrence of adhesions in such patients?
Yes. So that patient who was shifted from my hospital to another hospital because that patient developed in hospital reobstruction. And that is the reason why they shifted. One patient is still out there with a stoma. He developed on and off obstruction, but he is managing the thing. So yes, the risk of recurrence obstruction is also very high. But as I said, the amount of data is not enough to make any comment. But risk of recurrence is very high. By managing this patient, I think counseling is very important. Even if we do, so out of probably 9%, 2 or 3 cases in hospital, patient develop reobstruction. We manage the conservatively, and then the obstruction opened up, and then we discharge the patient. So reobstruction is very high, and patient dissatisfaction level is going to be very high. So counseling is paramount important in this patient, I think.
And in female patients, there will be an issue of reproductive functions also, right? Tubal adhesions and tubal block. And
yes.
Because when in adolescent girls, we deal with appendicitis, bad appendicitis, we do talk about this kind of complication.
Yes.
So over to other participants for their questions and comments. Yes, Jagdeep.
Yes. Congratulations, Dr. Jitendra, for your persistence, because perseverance is something which is very much important. And you have to be very gentle while handling the intestines, otherwise they give way. Most of the general surgeons in their life must have explored 2-3 abdomen where they found cocoon abdomen and don't know what to do with that. Another thing is I have seen one post-radiation cocoon abdomen after radiation therapy for cancer of abdomen. These patients survive because of super specialist team at KGP. Everyone from Dr. Kamna Gandhi, Nidhi Saini, Jalpa Dave, Anand Sarega, Hitesh Desai, and hospital did lots of financial assistance to support the patient.
Wonderful.
I actually scolded that patient on the follow-up because the 6 months, the cost at the KGP was very minimum. And even if that minimum cost, they asked for the discount. So on the follow-up, I scolded actually patient relatives that it should actually done to the hospital rather than asking the hospital to give discount.
Yes, any other comments? Hemant, do you want to say something? Yes.
I had 3 patients in 30 years, Jitendra. But I persisted on my day 1 because I got a laparotomy of a 16-year-old boy and he had a malrotation of the gut. No CAT scan was done. We opened the bowel as carefully as our teachers have said. We found a cocoon. We found his appendix on his left-hand side, a half a foot of a huge appendix, which I could not believe it is a bowel or appendix. We removed it. So one this thing is that you remove the appendix if you operate for the first time. Second, I persisted because I had seen in England that 27th time a 47-year-old female was being operated for Crohn's disease. So in India, we forget that Crohn's is not common, which causes repeated fistulas and fibrosis. In India, Yersinia or tuberculosis or idiopathic. So this boy, who is now a vice president of company school, he never came back to me. We operated for about 4 hours with saline jet, continuous saline being injected through syringes by the sisters, and we separated as much as possible all 420 centimeters of small bowel, washed it with saline and kept it. After on 10-12 post-operative day, he developed a fecal fistula, which was very minor. In our surgical language, it was grade 1. So they got very much anxious. And I said, only enteral nutrition will cure it. You may take second opinion. And believe me, on 20th day of a routine oral high protein diet, which I prescribed, and nutrition, he got cured. Other 2 patients, we opened the abdomen, cocoon had already killed the bowel. It was total gangrenous bowel, and we closed it. My question to you is, you had then a proximal ostomy. What about the distal bowel? How did you manage, and why did you not use the bile and the precious extract which are coming out to re-inject back into the distal bowel and use bowel as enteral therapy after few days of parenteral therapy? Because nothing heals bowel better, enterocytes better than food or nutrition. That is question number 1. And another thing is these fecal fistulas, they heal simply if it is grade 1. You know the classification and management, how to do abscess and all that. But if it is a minor fecal fistula, only in a normal patient who is passing his gases and bowels, only good enteral nutrition can heal the fistula. So why did you not use a bile and bowel on the distal loop?
So basically,
And
yeah. So whenever we face the problem that there is proximal stoma, we always make a distal loop also as a stoma side by or at some different place and use it as a distal small bowel feeding. But in this case, there was no distal loop. It was all mucosa perforated segments. Actually, when I first operated the patient, there was the whole small intestine, whatever segment was there, were into the 4 different segments. So, and those segments are also only mucosa rather than any actual bowel. So in this patient, I think the distal bowel district bowel was not technically feasible.
Correct. Injured bowel. So congratulations to the team KGP and you, and wonderful.
Thank you, sir. Thank you.
Such cases should be reported, no, as case series.
Yes, sir.
Some journals. You have so many publications to your credit.
I'm planning to write it, sir. I'm planning. Actually, writing is very interesting thing. Only thing is that it takes a lot of time. And as I said in one of my presentation in Kashiba, that the return of investment is direct return of investment is not much in writing.
I know. But it gives a lot of benefits to the readers, no?
Yeah, even I say it in the presentation that even it gives a lot of benefits to the writer also, but it doesn't appear like that. It's a very good thing to do. The amount of satisfaction you get in the writing is massive, but it needs a time and patience and environment where you can peacefully write and have a thought process for that. But yes, it is in the it is in the mind that I write these cases.
Dr. Jalpa is here. She was also involved in the team as nephrologist.
Yes.
Where kidneys also affected. Jalpa, any comments from you?
Yes, so indeed nice. Actually, I missed in between. There was one dialysis going on. I was in Kashiba, but indeed a nice presentation. And regarding writing, sir, as sir said, we have so many interesting cases, and even in Kashiba and as well as in private. But when it comes to writing with private practice and all, sometimes it becomes, like if you are determined that, okay, I have to write this case anyhow, then only it's possible. Otherwise, it's become a bit difficult because of that. You cannot get a complete 3-4 hours. Like at least you need a peaceful 2 to 3 hours to kind of do such kind of thing. So it cannot be done like partly, like okay, half hour. I will do in between the OPD or in between the work schedule. It is sometimes it's very difficult, I guess. I don't know about sir, but I think I need at least 1 or 2 hours only dedicated to this thing. Right.
So I'll tell you one story, and Dr. Jalpa. So actually, I completely confess that the Gangaram Hospital training has a massive impact on my career and my life. So the GI surgery and transplant was a common department. It was a very hectic department. I mean, we start at 6 o'clock in the morning and we finish at 12 o'clock or 2 o'clock at night. That is how the operation theater and everything was going on. And I was also of a mind. Even today also, I feel that we should get a 2-3 hours of continuous period peaceful for the writing. But in that department, I observed that every resident and consultant used to move with a small mini laptop in their hand. Whenever they get time, they'll just open the laptop and then they do something. Whenever they have to go in the OT, they'll close the laptop and do something. That is how they manage. At any point of time, 35, 50 publications were in the process in the department. So that is one thing. I think it's a mindset. I'm also, even in private practice, I'm also feeling that I should get a time, and last 3-4 months, I have not been able to write anything. But yes, it's a mindset. And Dr. Nandi always used to say that the private practice without academic is useless and boring. And I'm holding that sentence in my mind, and that is actually inspiring me to continuously write something.
My comment is
I actually feel that only private practice, it doesn't give a peace of mind. But when I write something and something gets accepted, it gives a different kind of
return on your investment of time.
Yes.
Then KGP Children Hospital is a teaching institute along with a research center with an ethics committee also, with I think sizable number of residents with you. So
yes, sir. So that will be a blessing. Because of KGP, we keep feeling motivated to write something. And
I must say that KGP has a massive potential which is unexplored.
Absolutely.
Yes.
Developing one of the finest academic institute, one of the finest probably pediatric GI department. It is probably the only hospital in the state I know which has a pediatric nephrologist, pediatric gastroenterologist, pediatric surgeon, infectious disease specialist, everything. Probably there is no any hospital in the state which has all pediatric subspecialists available in the
Very true,
hospital.
very true. Under one roof, so many things are available. So
Yes.
thanks to
There's a
visionary
massive
like Dr.
potential.
Jagdish Bhai and his team of management trustees.
Yeah, I wanted to tell Jalpa, wake
Yes,
up
sir.
at 3 o'clock in the 3 o'clock in the morning, write what you want to write, and sleep again for half an hour. That's what I have done in my life.
Okay, right, sir. I should keep this thing in mind. We'll try this.
That's right.
Something has to
So-
be compromised. Either private
Yes,
practice
yes.
or sleep. Either private
Yeah.
practice or sleep.
It is such a peaceful, cool atmosphere at 3 o'clock in morning.
Yes.
No one to disturb
Yes.
you. You can be creative, write what you want to, spend 1 or 2 hours, and then have a nap for half an hour. You are fresh for the day.
Right,
But
sir,
I must
right.
say it is very difficult. It is very difficult.
It is
It
more
very difficult.
difficult for a lady, woman, to manage
Okay.
everything in the house.
Okay, friends. So on this very good, inspiring note that research and writing is possible even in private practice, especially when you are with teaching institute. I think with this note, we end the session here. Thank you, Dr. Jitendra, once again for bringing out a wonderful case management. And we look forward to many more such talks in future. So thank you all. We end the session
Thank you.
here. We meet next Saturday morning again. Thank you all.
Thank you. Thank you, everyone.
Thank you.